can't intubate, maybe you need to pray the God so that you can establish some sort of the surgical airway. It is gone. You are going to high chance that patient is going to have hypoxia and cardiac arrest and all. You need to be very, very careful, okay. So again, this is one more score, so which include multiple parameters, grading between like more than 5 points, which means, so awake intubation is the choice. More the score, the morbidity and mortality. Ultimate idea is, and we are not able to establish the airway. That is very, very essential, okay. So this is some again open the airway and all. So again, if patient injury, you can't be of mobilizing, okay, will give extension. Obese patient, they desaturate very rapidly. Next is the wire. It is not like FRC is at par with like adult patient and all. Next, the adult critically ill patient. Capacity of the is not 100% proof. Always you need to go for ETCO2 confirmation. So waveform ETCO2, or we have something called qualitative capnometric device, okay. So there is a litmus paper in that device. So when the ETCO2 touch that litmus paper, so with a particular value, it changed the color, okay. So if the ETCO2 is less than 3, then the color become purple. So it tan for 3 to 15 ETCO2. If more than 15 ETCO2, it means like you put the tube inside the trachea. Up to 15, you can have the ETCO2 in the stomach also, because when you like do some sort of umbu ventilation, there is a aerophagia. So air will go into the tummy. So air contains carbon dioxide. That's why just having ETCO2, it doesn't make like you ruled out esophageal intubation. The quantification value is also very, very important, and the curve in waveform capnography is also very important. So then there are devices like esophageal detector devices, so which are advanced. So we can use, okay, there will be some sort of cuff will be there. If it is inside the trachea, if you just like push it, it is going to reinflate back. If it is in esophagus, it is not going to reinflate back. It is very simple. So that is called esophageal detector device. So recently, in the last 5-6 years, we have lots of data on ultrasound confirmation of your endotracheal intubation also. So this is what we call it as something called double tract sign, okay. So usually when there is no endotracheal tube inside the esophagus, you will not see the esophagus. Esophagus is seen as a collapsing structure, because it doesn't contain air. But when you have an endotracheal tubule accidentally inside the esophagus, so then one is the tracheal image, one is the like image because of your endotracheal tube which is present in the esophagus, that we call it as a double tract sign. So then this is the data on ultrasound utility for confirmation. So this is the crash airway algorithm. You can go through these busy slides, okay, just to make your work easy. So everything is put as a protocol, as an algorithm. Again, this is the failed airway algorithm. So whatever I have spoken, so everything is been put systematically. We have difficult airway society like algorithms also. This is for tracheal intubation of critically ill adult patient. In the same way, suppose you stuck with can't intubate, can't oxygenate in critically adult patient, what you need to follow. So these things you can go through. So ultimately, if you are not able to put endotracheal tube, we can use rescue airway, that is laryngeal mask airway. There is something called combi tube, bougie assisted like intubation, and that of the surgical. Something called combi tube. So basically combi works both as an endotracheal tube and a supraglottic airway device, that is a laryngeal mask airway. We have intubating LMA, okay. We have like C-track, P-track, so many video assisted laryngoscopies also we have, so where we can use them as a rescue therapy for intubation, okay. So basically, careful dosing of your anesthetic agent is very essential. So in patients who are with a shock, you have to choose the agent very carefully. So difficult airway guidelines, preparation is very, very essential, okay. So last part is, suppose ultimately you are not able to establish, you failed in oxygenating the patient, we can go for something called cricothyrotomy. In the cricothyrotomy, we have a needle cricothyrotomy or open surgical cricothyrotomy. Why we choose this cricothyroid membrane, which is present in between the thyroid and the cricoid cartilage? Because it is fairly avascular, means like if you cut it also, it will not bleed. So otherwise, if it is vascular, when you are cutting it, so then you land up with a bleeding, you are not able to establish the airway, so then patient will aspirate. That's why we go for cricothyrotomy. We do tracheostomy just to wean the patient. It is not an emergency procedure. Cricothyrotomy is an emergency procedure, okay. So without practice, you can't do the cricothyrotomy. We have something called needle cricothyrotomy also. There are some specialized needle will come with a jet ventilation. We can pass that needle and we can connect to high frequency jet ventilation and we can save the patient, okay. So suppose you assume like you established the intubation in a particular patient, very essential post-intubation stabilization, maintain adequate ventilation and oxygenation, maintain the hemodynamic stability, acid-base balance, electrolyte balance, so adequate sedation, paralysis, oral care, eye care, skin care. So when you put the like endotracheal tube sticking also, you have to be very, very careful. Otherwise, after 2-3 days, it will cause like sores or maybe injury, skin peel and all. So all these things in the post-intubation, you need to take care. So the take home, maintaining and securing a patent airway is primary goal in any emergency and difficult. So difficult airway situation, intubation in ICU is definitely a challenge, so but not impossible. If we know correct technique, okay, so we can intubate the patient without any sequelae. So recognize the difficult airway. How much time do you have to intubate that patient? Who else is around? Okay, whether you have your senior colleague or your junior colleague, that also makes the difference when you are establishing the airway. What is your backup plan? Suppose you are not establishing airway in first attempt, what is the second attempt? Means whether you are going to use LMA or you are going to just bag mask ventilation or you are going to use bougie or the stillet, okay? So know both old and new technologies, new methods of intubation. Choose backups based on your skills. Don't experiment during the emergency. So you should pass through many of the workstations, workshop before you do the final and real scenario. Thank you. Any questions? Who are from at least respiratory therapy background, so when you get your clinical postings, so maybe like second year, third year BSc artists will get hospital postings and all, just have some curiosity what happens in and around intubation and all, okay. So at least you might not get hands-on, so at least when you see, when you visit ICU and all, during your 3 year of tenure, at least 1 or 2 intubation you should see, okay, what happens, what they do, how they prepare and all, okay. So that should be your take home. Thank you. Thank you all.
I welcome our principal, Dr. Venkatesh Jayadath sir, to felicitate our speaker.
Acharya institutes. This event symbolizes a celebration of knowledge, innovation,
The ceremonial lighting of the lamp symbolizes the triumph of knowledge over ignorance. Thank you, sir and ma'am.
Our theme, Innovation Through Collaboration, highlights an essential truth. Meaningful process in healthcare cannot happen in isolation. It demands partnership between disciplines, between institutions, between researchers and clinicians, between educators and learners. When expertise converges, innovation accelerates. We are deeply honored by the presence of our respected principal, sir, Dr. Venkatesh Jayadit, whose visionary leadership and commitment to academic excellence continue to inspire our institution towards greater heights. I would also like to request Ms. Kirti Rajan, Lecturer, Department of Medical Lab Technology, to welcome our respected principal, sir, with the sapling. We are equally privileged to welcome our esteemed keynote speaker, Professor G. Vishalakshi, whose remarkable contribution to health education and professional development have significantly enriched the field. I would like to request Professor Priyanka Patnaik, Department of Optometry, to welcome our esteemed keynote speaker with the sapling. I would also like to welcome Dr. Sarita Kamath, Professor and Head, Department of Medical Lab Technology, MAHE. I would like to request Ms. Joby Mole, Assistant Professor, Department of Medical Lab Technology, to welcome our esteemed keynote speaker with the sapling. I would also like to welcome Mr. Rishabh Majumdar, Product Owner, MR Scanner R&D, Siemens Healthineers Bangalore would like to request Ms. Kirti Rajan, lecturer, Department of Medical Lab Technology, to welcome her with the sapling. I would also like to welcome Mr. Puneet, Assistant Professor, Ramaya University of Applied Sciences, Bengaluru. I would like to request Ms. Joby Mole, Assistant Professor, Department of Medical Lab Technology, to welcome him with the sapling. I would also like to welcome Iqbal sir, Director of HR. I request Ms. Joby Mole, Lecturer, Department of Medical Lab Technology, to welcome him with the sapling. To our distinguished panelists, faculty members, researchers, and student delegates, your participation makes this conference a vibrant platform for dialogue and discovery. Today is not merely about listening. It is about exchanging ideas, questioning perspectives, building networks, and translating knowledge into real-world impact. I would also like to acknowledge the dedicated efforts of the organizing committee and volunteers whose hard work has made this event possible. As we begin the academic journey together, may this conference spark innovation thinking, strengthen collaborative bonds, and inspire each of us to contribute meaningfully to the future of the healthcare. Once again, I extend a warm and heartfelt welcome to each one of you to AIAHS 2026. We are honored by your presence and look forward to a day filled with insight, dialogue, and inspiration.
It's now my honor to invite our respected principal, Dr. Venkatesh Jayadat, whose visionary leadership and unwavering commitment to the academic excellence have played a significant role in the impact of healthcare, education, and research initiatives at Acharya Institute. May I request, sir, for a presidential address at the gathering.
Thank you. So, looking at the crowd here, I'm so happy that all of you people have made it to our conference. And we sincerely regret if you have some inconvenience sitting there. It is only for a short time. And after this, we'll all be dispersing to our respective departments for starting of our program, of our conference. So I have a workshop. So respected Dr. Vishalakshi ma'am on the dais, who is going to give us our guest of honor today, Dr. Sarita Kamath, head of the department from KMC Manipal, and lot of other dignitaries, like Puneet, Mr. Rishav, and all the other dignitaries who are here. And also we welcome Ms. Jenisha from Reva University to come here and grace our function. And Professor Iqbal, who is very close with us, he is Director of Collaborations and our Head HR, Director of Head HR. So he's taken his, even though today was his off day, he took off his, off day and he's come and attending our program, sir. Thank you so much for gracing the occasion. So, as a presidential address, I don't want to speak much because I know all of you people are ready to get into the academic part of it. But anyway, all the faculty members, all my colleagues, all my organizing committee members, all the teachers and my dear students, we welcome you all. I hope you people will have a wonderful time here in Acharya. And the theme of AIAHS 2026, Innovation through Collaboration in Health Sciences, will ring a bell and will be help to you in your future endeavors. Thank you, all the best. Welcome to Acharya and enjoy Acharya hospitality. Thank you.
I would now like to invite Dr. Sarita Kamath, Professor and Head of the Department, Medical Lab Technology, MAHE, to address the gathering.
Thank you. So, good morning all. So, very happy to see this big crowd. So, I am honored to be a part of this inaugural ceremony. So, thank you for inviting me as a guest for this function. So in this lecture, I would like to remember our government, India's healthcare ecosystem. So budget 2025-26. So thinking to initiate 10 institute for allied health professionals. So this definitely a effort which makes to this healthcare facility reach each and every one of our India's citizen. So I am happy to remember those things in this situation. And again, so we are going to start the National Commission syllabus in the coming year. And at this point, so our Acharya Institute of Allied Health Science initiated this conference thinking that very good theme, that is innovation and collaboration. Yeah, we are having very good team and we can do so many things by collaborating than individually. So in this lecture, I would like to congratulate and thank you for each and everyone. All the best.
It is now time to introduce our esteemed keynote speaker for the day. We are deeply honored to welcome Professor G. Vishalakshmi Ma'am from Padma Shri Institute of Medical Lab Technology. Vishalakshmi Ma'am is a dignified academician and a thought leader in medical lab technology with years of experience in education, research, and mentorship. She has contributed immensely to advancing allied health education and professional standards. Ma'am, we are privileged to have you with us today. To give a brief note of her profile reading, I request Mr. Prince James S. Bangira, HOD of Hospital Administration, onto the stage.
Good morning, everybody. Good morning, respected dignitaries on the dais and off the dais. I would like to introduce to you all Professor Vishalakshmi Madam. A brief introduction about Madam. Ma'am has worked as a lecturer at Sri Siddhartha Medical College, Tumkuru, in the year 1994 to 2025. Madam has worked as assistant professor at College of Medicine, International Medical and Technological University, Tanzania, from 2005 to 2006. Madam has worked as associate professor at Padma Shri Institute of Medical Lab Technology, Kengeri. In the year 2008, ma'am started there and until 2018. Ma'am has worked as Dean at Acharya Institute of Allied Health Sciences, Bangalore, in the year 2019 and 20. Vice Principal at Saptagiri Institute of Allied Health Sciences, Bangalore, 2020-2021. Ma'am is currently working as Professor at Padma Shri Institute of Medical Laboratory Technology, Kengeri, from the year 2021 till date. Ma'am has almost 30 years of experience teaching diverse group of students. Madam is instrumental in formulating syllabus and question bank for BSc and MSc Medical Lab Technology. Madam has been a resource person for various workshops and seminars conducted, core committee member in organizing state level and national level conference and workshops. Madam has been a guide and co-guide for over 30 MSc MLT student projects, has published articles in both national and international journals. As a part of medical education unit under PGI, Ma'am has coordinated the publishing of the following books: Handbook on Error-Proofing Clinical Laboratories, Research Methodology and Manual, Good Clinical Laboratory Practices Manual. Madam, it's an honor and privilege for all of us here at Acharya Institutes to have you as our keynote speaker for the very first national conference, ACAHS 2026. The stage is all yours. We are anticipating to listen from you. Thank you.
Thank you so much, Prince. A very good morning to one and all present here, respected dignitaries on the dais, distinguished faculty, esteemed clinicians, researchers, students, and my fellow allied health professionals. It is both an honor and responsibility to stand before you today to speak on a subject that is not only timely but transformative. The theme for this national conference, the first national conference by Acharya, Alliance 2026, has made me, can I have my presentation, please? So with the theme in mind, I would like to speak on allied health sciences as strategic pillars in transforming healthcare from collaboration to impact. I think this is going to be very apt with the council coming up. We are getting power and will be not just backgrounds in the healthcare sector, but will be the strategic pillars. With that aim, for decades, allied health professionals were often described as support systems. Today, that description is no longer sufficient. We are not the background for healthcare. We are not the periphery of patient care. We are not optional components of the system. We are strategic pillars. And when pillars are strong, the entire system structure stands stronger. The allied health professionals have evolved from being perceived as the secondary support roles to becoming integral strategic components of healthcare delivery. A strong healthcare system depends on the strength, integration, and recognition of allied health professionals. The shift reflects changes in complexity, technology, and patient-centered care. Allied health professionals were once viewed primarily as support services, necessary but secondary. Today, that narrative has fundamentally shifted. We are now recognized as strategic pillars of healthcare system, integral to quality, safety, and outcomes. Do we agree to all that? A big cheer to all of us. Thank you so much. Allied health has evolved from coordination to true collaboration. The main challenge that we experience is the fragmentation in healthcare. Modern healthcare is advanced beyond imagination. We have robotic surgeries, we have precision diagnostics, artificial intelligence-driven imaging, smart dialysis machines, electronic health records. We have advanced diagnostic tools, AI-powered analytics, and cutting-edge treatments, yet systems remain siloed and fragmented. And despite this advancement, one major challenge persists, that is fragmentation. When a patient enters into any healthcare system, they face a lot of sections. Patients interact with multiple professionals across diagnosis, treatment, rehabilitation, and monitoring. Patients encounter laboratory professionals, a radiological technologist, a dialysis technologist, a respiratory therapist, an occupational therapist, a vision therapist, ICU technologist. Each professional performs their role with competence and dedication. But if these roles function in isolation, the patient experiences disconnection. Healthcare does not fail because of lack of intelligence. It fails because it lacks integration. Disjointed systems can lead to duplication, inefficiency, communication breakdowns, and compromised outcomes. This is where allied health sciences emerge as strategic connectors. There are two components. One is coordination, another one is collaboration. What is coordination? Coordination means aligning tasks and ensuring handoffs occur. It's necessary but insufficient. What we require truly is collaboration. Collaboration means shared knowledge, accountability, mutual respect, and collective decision making. It transforms how care is delivered. True collaboration improves outcomes across the entire continuum of care, from prevention to recovery and beyond. We are present across the entire continuum of care. We are there in diagnosis. We are there for intervention. We are also present in rehabilitation and for long-term monitoring. When collaboration replaces coordination, outcomes improve. Coordination is logistical. Collaboration is relational. Coordination says, I have done my part, whereas collaboration says, we are responsible together. And that shift changes everything. Coordination ensures tasks are completed and handoffs occur. Collaboration involves shared accountability, mutual respect, and integrated decision making. That's the reason the topic that Acharya has selected, collaboration to transformation, that is why it has a real impact in allied health sciences. While coordination is necessary, true healthcare transformation requires collaborative culture across disciplines. Collaboration enhances outcomes across prevention, treatment, rehabilitation, and long-term monitoring. We are there across the entire process of a healthcare system. We are involved throughout the patient's journey, from diagnosis to intervention to rehabilitation and also in monitoring. There was a time when patient safety discussions centered primarily around doctors and nurses, but today we know something deeper. Patient safety is co-created. A laboratory personnel ensures internal quality controls, prevents misdiagnosis. A radiographer, following radiation safety protocols, protects both patient and environment. A dialysis technologist monitoring hemodynamic changes prevents life-threatening complications. A respiratory therapist managing airway precision in ICU saves critical seconds. An occupational therapist assessing home safety prevents repeat hospitalizations. Safety is not a department, it's a culture. Patient safety has evolved from a focus on avoiding errors to a comprehensive approach that values prevention as much as treatment, and allied health professions are the guardians of this culture. When we talk about transforming healthcare, we must ask, are we measuring our treatment success or are we measuring prevention of harm? True transformation occurs when preventable errors decrease, when hospital-acquired complications reduce, when readmissions drop, when rehabilitation restores independence. Patient safety is not owned by any one profession. It is a shared ethical commitment. The prevention of harm is as important as the success of treatment. When every team member embraces safety as their responsibility, outcomes improve system-wide. I think it's the previous slide. You have skipped one slide. Allied health functions as a frontline defense in safeguarding patients' well-being. We significantly impact patient safety through accurate diagnosis, effective treatment, and error prevention in healthcare settings. For example, a lab control, quality control does rigorous testing protocols so that there are no misdiagnoses. A dialysis technician monitoring continuously patient monitors and equipments checks prevents life-threatening complications during renal replacement therapy. A person involved with radiation protocols gives precise dosing calculations and safety protocols, protects both patient and staff from unnecessary radiation exposure. We also have occupational therapists who learn safe mobility and daily living skills, reduces fall risk, and prevents hospital readmissions across discharge, after discharge. Allied health roles are not static, they are evolving. They are expanding beyond traditional task-based functions into strategic decision-influencing positions throughout healthcare organization. Take laboratory sciences, for example. Where do we find? Earlier, we were perceived to be behind the scenes, but now we see that the laboratory professionals are involved with a lot of decision-making in the laboratories. They are partners in antimicrobial stewardship, contributors to early disease detection, experts in quality assurance system, custodians of diagnostic data analysis. As diagnostics move closer to point-of-care testing and bedside analysis, oversight responsibilities increase but not decrease. Similarly, consider radiologic and imaging professionals. With innovations like helium-free MRI systems and AI-assisted imaging, sustainability improves, accessibility expands, precision enhances. But technology alone does not ensure accuracy. It requires skilled professionals who understand physics, protocols, patient positioning, safety, and interpretation support. In hemodialysis, smart machines now offer real-time monitoring, predictive alerts, and personalized treatment parameters. Yet it is the human judgment of technologists that translates data into action. Allied health professionals are no longer task-oriented executors. They are decision-influencing, outcome-driving contributors. That is of strategic influence. I think we all know we have to address artificial intelligence, which is getting into every field. So what many professionals quietly wonder, will AI replace us? The answer is clear. AI does not replace allied health professionals. AI amplifies them. Artificial intelligence is already enhancing image clarity and diagnostic speed, supporting predictive analytics and dialysis, improving workflow management, optimizing hospital resource allocation, assisting in early detection algorithms. But AI does not feel pulse irregularities. AI does not comfort anxious families. AI does not adapt when unexpected variables arrive. AI does not take ethical responsibility. AI processes data, professionals interpret meaning. The future of healthcare is not AI versus healthcare professionals. It is AI with healthcare professionals. The responsibility, however, lies with us to understand AI, to question its limitations, to advocate ethical implementation, to ensure inclusivity and patient-centric deployment. We must not become passive users of technology. We must become informed collaborators in technological evolution. That is how innovation becomes impact. Stay informed about AI, what AI can do and what it cannot do. Recognize where human judgment is irreplaceable and where, where AI adds value. Ensure AI tools, Ensure AI tools are transparent, fair, and validated. Champion policies that protect patient privacy and prevent algorithmic bias. Technology should serve patients, not the other way around. Keep the human experience at the center of every AI decision. Care delivery models, not just operating within them. Transformation must also consider sustainability. Helium-free MRI technology is one example of environmentally conscious innovation. But sustainability goes beyond equipment. It includes reducing unnecessary investigations, minimizing medical waste, promoting preventive healthcare, equitable access to services. Sustainable practices ensure long-term system resilience and social responsibility. Modern healthcare leadership demands we balance innovation with responsibility. As we adopt new technologies, we must consider environmental impact, prioritize preventive care that reduces future burden, and ensure every advancement reaches undeserved population. Choose eco-friendly medical technologies and reduce waste. Shift from reactive treatment to proactive procedures. Design interventions accessible to all communities. In our enthusiasm for technology and collaboration, let us not forget, healthcare is human. Compassion, empathy, trust, and therapeutic relationships significantly influence recovery and adherence. We are educators, listeners, motivators, and advocates. Technology enhances care. Humanity defines it. Excellence in, next slide. Excellence in allied health requires unwavering commitment across 5 critical dimensions: collaboration, patient safety, technology research, and measurement. As we look to the future forward, the path forward demands 5 commitments. I think you all should take these commitments. Commitment to collaboration, breaking silos permanently. Commitment to patient safety, making it a shared culture. Commitment to technology literacy, engaging with AI responsibly, commitment to research and measurement, proving impact through data, commitment to leadership, influencing systems, not just functioning within them. If we uphold these commitments, allied health sciences will not merely participate in healthcare transformation, we will lead it. When allied health rises, healthcare systems rise alongside them. Allied health professionals stand as strategic pillars of modern healthcare systems, guardians of patient safety, champions of innovation, and architects of compassionate care delivery. Our collective commitment to excellence, collaboration, and evidence-based practice will define the next era of healthcare information. Let me conclude with this reflection. The future of healthcare will not be defined by one breakthrough device, one algorithm, or one specialty. It will be defined by how effectively diverse professionals work together to produce measurable improvements in patient outcomes. Allied health sciences are no longer silent contributors. If we work as one group, we equip to carry this forward. It is the allied health community gathered here today, which has a major role. Let us move forward confidently. Let us transform coordination to collaboration. Let us convert innovation into measurable impact. And let us build a healthcare system where every professional's contribution is recognized as essential. Thank you. Wishing you all a meaningful and transformative journey. And I also congratulate Acharya Institute of Allied Health Sciences for this first national conference. I hope you have a wonderful future ahead. Thank you so much.
Thank you, ma'am, for that enlightening and thought-provoking keynote address. Now, it's my privilege to introduce Mr. Iqbal Ahmed, Director, Collaborations and Growth at Acharya Institutions, Bengaluru. An electronics engineer with an MBA, Mr. Iqbal Ahmed brings over 3 decades of distinguished experience to information technology, higher education strategy, and institutional development. He has also served on the expert evaluation committee of the NEET, AICTE, Ministry of Education, and is a former chairman of the Computer Society of India. Today, he will be delivering the technical session on AI and healthcare.
Morning, everybody. I will try to make it as lively as possible, okay? And I would want you people to pay attention. See, I'm a speaker at the national and international level, and a recent book of mine which I have published, Restructuring and Consolidation of Higher Education Institutions. There is a chapter on AI in healthcare. So I'll see this same talk I delivered to pharmacy students. It took 3 hours. Dr. Vijayadath was getting afraid when I said 3 hours. Okay, so I'll try to rush through. See, what I will do is I will touch upon, see, everybody's talking about AI. So I will touch upon what is AI, how machine learning, deep learning, all the things are used in healthcare. Okay, and I will define the different types of AI which are being used in healthcare. Okay, so I would want all of you to pay attention, and in case you have any questions, you can ask me. No talking in between, please. See, I'm a person who does not like to be disturbed. If I find anybody talking, I will ask you to get out of the room. Okay, this is my way. Okay, now, either I talk or you talk. Now, just let me start. Things have changed. The way business is done, the way transactions are done, the way we interact, the way we communicate. Okay, everything has changed. When I did my engineering from RV College, we did not get to see computers. Later, I was heading the complete IT, this thing for India. Okay, so, my dear friends, even transactions, you can book your flight ticket, you can this thing, you can communicate with anybody across the world. And tons of data is available with a click of a mouse. See, I was in US, must be before COVID, in one of the universities, and it was a medical university. The provost asked me, please deliver a talk. Then, I mean, just suddenly she said, and medical students, what do I talk to the medical students on? So I was just walking across. I'm a technology person. Okay, anyway, I walked to the room and then the American students were sitting. I said, are you people aware about IoT? They said no. I said, great. Okay, so then I started talking about IoT and then I linked it to remote patient monitoring. Okay, how wearable devices are being used, how sensors are mounted on the wearable devices, how the parameters are measured, how the parameters are sent to different hospitals, and how the critical level is fixed. Suppose your heartbeat goes up, your BP goes up. There's a critical level that is fixed. Okay, and then it goes to the nearest hospital. And if it goes beyond the critical level, immediately the hospital sends an ambulance. How you're picked up. This is remote patient monitoring. If a person falls down, he's not able to get up, there is a sensor device which sends a signal that this person has fallen down. And the algorithms, the vertical algorithms and the horizontal algorithms come into play. So, my dear students and friends, technology is come to the core. Technology plays a vital role. When I was trying to bring about computerization in India, okay, a lot of people opposed it in North India. So now, technology thread runs through everything. And in case you want to stay away from technology, you will become obsolete. Whether it's engineers or doctors or healthcare professionals, technology is a necessity, technology is a must. Okay, now all of you, see what I'll do is today, I'll try to rush through. Now it is 11 o'clock. Okay, a little bit I might have to rush through to touch upon all these things. What is AI? Everybody is speaking about AI. What is artificial intelligence? Can anybody explain to me? Just a division of computer science that makes systems and computers. Okay, that makes systems and computers carry out tasks having intelligence with that same as that of a human being or beyond that. There are 3 different types of AI. I'll come to that later. Generalistic AI, broad AI, and super AI. Okay, I'll not get into all these things. Okay, so basically trying to embed human type of intelligence so that the systems and computers can analyze data, can take decisions just like human beings. Are you able to understand? See, because without understanding, there is no point in me just giving lectures. Okay, now we also have neural networks. I'll be touching upon neural networks also. So AI is usually perceived as a synonym for deep supervised machine learning. Okay, now what is machine learning? Next slide. So I'll just explain machine learning. Now see, what happens is, there are certain things that the computer or the machine is not aware about. We are using training data or structured data to train the machine or the system. That is called as machine learning. Example, a small kid is there. You put some different color cups. And then you will say, it's blue color, oh, this is green color, this is yellow color. And then the child will repeat, this is yellow. Okay, so you are training the system. That is called as, okay, so training data or structured data, you are training the data, training the system, that is called as machine learning. Is it clear? Yes or no? Okay, so we have 3 different types of AI. Now see, the world IP, that is Internet World IP, that is Intellectual Property Organization, has defined AI. It has accepted the presence of AI, and they have said there are 3 types of AI. First one is expert systems. Expert systems are those systems that go deep into the thing, like medical diagnostics, etc. These are called as expert systems. See, I'm not going deep into it. Okay, perception systems. Perception systems are those which make the machines hear and see things like a human being. Understand? That make the machines hear and see things like that of a human being. These are perception systems. And next one is natural language program. I'll be explaining this. Okay, which understand the meaning of words, grammatical text, everything, contextual this thing, that is called as natural language processing. Next one. Next one. I think we'll have to move fast. Okay. Now, there are different things: traditional AI, machine learning, generative AI, and agentic AI. Before I jump into these things, see, nowadays there are two important things: generative AI and agentic AI. Very, very important. Generative AI is your chat GPT, for example. Okay, which can generate a lot of data. That is generative AI. See, these are very important things you will not get anywhere else. In case you want to note down, please note down. Okay, very important things. Next thing is agentic AI. Okay, agentic AI, autonomous decision-making systems, where you have bots performing human tasks. So they are going to replace human beings. Yes, let me tell you. Okay, they are going to, bots are intelligent systems that perform the works of the human beings. Okay, so first level diagnosis of the disease, all these things can be carried out by the agentic AI systems. The bots can do. Bots are intelligent systems, okay, performing the tasks of human beings. Next one. Okay, next one. Okay, now machine learning, like I explained, it uses input and expected output, that is called as structured data or training data. I think I've explained this. I don't want to get into this again. Okay, next one. Now, yeah, no, previous one. Machine learning. Okay, now let me come to this. Most of the companies were using machine learning. In healthcare, the most traditional machine learning is precision medicine, predicting what type of medicine is suitable for that person. They study the protocols. They study the effects that the person has had. Okay, what was his behavior? What was his reaction? Okay, all that data is taken, and based on that, the best medicine that can be advocated to that person is done through machine learning. Okay, so they study the various patient attributes. Okay, now, okay, next thing is, we also have machine learning in precision medicine applications. This is called as supervised learning. Next one. Next one. ಸ್ವಲ್ಪ ಬೇಗ ಮಾಡ್ತೀರಾ, ಟೈಮ್ ಕಡಿಮೆ ಇದೆ. ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್. Next slide. If you're going to waste my time, it's going to be ಯಾಕೆ ಸರಿಯಾಗಿ ಮಾಡ್ತಾ ಇಲ್ಲ? ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ಮಾಡೋಕ್ಕೆ ಆಗಲ್ಲ. Okay. Okay, now, I think there is one more before this. One more before this. One more before this. Okay, next one. Fine. Now, deep learning, neural networks. Now, neural networks have been in existence. After I did my engineering also, I have what you call, through Computer Society of India, I have seen many papers on neural networks. Neural networks, basically, they work same as neurons. Okay, and the signals are sent to the brain and how the brain processes. Same thing neural networks do. Some people don't agree with this analogy. Anyway, let us not get into it. Common application of deep learning, not any robotic this thing. There is a program that is there in the computer, and all the and AI is used at the back end. So these programs, this is called as robotic process automation. Okay, and it is a computer program. It relies on a combination of workflow, business rules, and presentation layer. So this is used to extract data, combine a lot of things, and then analyze the data also. Next one. IBM Watson, I think you people know. It is also used for diagnosis. and it claimed that it can be used for detection of cancer, but some places it has failed. Okay, so I don't want to get into IBM Watson this thing, whether it's good or bad. Next one. Next one. Next one. Next one. Okay. I'm trying to rush through because of limited time. Okay, so why do we need AI in healthcare? Growing patient load, shortage of healthcare professionals, rising healthcare costs, need for precision and early diagnosis. Next one. Okay, now AI in medical diagnosis. Radiology and imaging, X-ray, CT, MRI. Pathology and histopathology, early detection of cancer and chronic diseases, clinical decision support systems. Next one, AI in treatment and care, personalized treatment plans, robotic assisted surgery, AI-driven drug discovery, smart therapy recommendations. See, there are a lot of patents that have been filed using AI. I don't want to get into it. I'm a speaker on the IPR also. Okay, and whether AI, there is a contradiction between AI and patents, because the European Union said any patent that is developed by a human machine cannot be granted a patent, because when you say intellectual property rights, it has to emanate from that of a human mind. Understand? Anything that is emanating from a machine or from an animal or somebody else cannot be allowed. Courts have ruled this in San Francisco also. Next one. So in patient monitoring, wearable devices and remote monitoring. Predictive analytics for patient deterioration, ICU monitoring systems, chronic disease management. Next one. Next one. Next one. Okay, next one. I don't want to get into all these things. Next one. Next. Okay, now, I'm rushing through. Okay, you have to bear with me. So, we have different models. LLM is the large language model. Okay, LLM is the large language model ecosystem. Then there is also multimodal AI. Then we have AI augmented workflows. These are this thing. Now, difference between LLM, that is the large language models, and generative AI. LLM helps to build generative AI applications. Where is generative AI used? Anybody? I just spoke about generative AI. For example, ChatGPT. Okay, good. Okay, and generative AI focuses on generating new content based on its training data. You provide some training data. Based on that, it is going to generate information. While LLMs concentrate on learning from and interpreting data to generate reliable text outputs. Next one. Next. Okay. Now, what is generative AI? AI that creates new content based on prompts. Generates text, images, audio, video, or code. Works when a user provides instructions. Performs this thing. Okay. Now see, ChatGPT, what you people use, is a bit old. There is a professional ChatGPT. That is a paid version. Okay. So whatever data you get must be about 3 years back. Okay. Whatever is processed about 2 years back, 3 years back. The professional version gives you the exact recent developments that are there. Okay. So next one. What is agentic AI? AI systems that can act autonomously to achieve goals. Can plan multi-step workflows, use tools, application, APIs and external systems, and makes decision and adapts during execution. Example, autonomous AI assistants managing tasks. Next one. Okay, next one. Okay, now example, generative AI, like a skilled writer who produces content when asked. You ask it, then it produces the content. That is generative AI. Now, what is agentic AI? Like a project manager who plans the tasks, coordinates everything, and completes the objectives. Is it clear? Okay, I think this example clarifies everything. Yes or no? Next one. Okay, what is agentic AI? AI systems that autonomously pursue goals, can plan, decide, and execute multi-step tasks. Uses reasoning, memory, and tools. moves beyond reactive AI to proactive AI agents. Reactive to proactive. See, when I spoke about Industry 4.0, anyway, I don't want to get into it. We have what is called as cyber physical systems, in which you have preventive maintenance and predictive maintenance. Preventive maintenance was being done earlier. Okay, predictive maintenance, it should predict when that thing is going to fail, when it's going to happen. So here what happens is, it is proactive, it also gives predictive failure of any human being. Understand? So it also does prediction. Predictive analysis also is done. So if a heart attack is going to happen, it's going to predict. Based on various parameters, it is going to predict. Next one. Okay. Agentic AI, it is goal-oriented, autonomous, ability to use. Next one. Okay. See, agentic AI can perform tasks. First level of doctors' tasks can be performed by agentic AI. Is it clear? First level. So is it going to replace the first level? Yes. I will say yes. Let me blatantly tell you, yes, it is going to replace a lot of first level doctors. Okay. Agent is a bot. What do you mean by agent? Agent is a bot. Okay. Agent is a bot performing human tasks. It is also called as digital colleagues. You will not get this explanation anywhere. Please remember. Okay. These are called as digital colleagues. Is it clear? Next one. Next one. Next one. Next one. I don't want to get into too much detail. Next one. Okay. Applications in healthcare. These are all the applications. Next one. Okay. So, use cases, AI clinical agent workflow, that is collect patient data from EHR, analyze systems and history, suggest possible diagnosis, recommend tests, assist doctors in treatment planning. Next one. Okay, next one. Okay, challenges, I don't want to get into the challenges. Okay, next one. See, wherever this thing is there, it has to be supervised by the human doctors. Robotic surgery also, it has to be supervised by human doctors also. Okay, next one. Okay, so agentic AI represents the next phase of healthcare in AI. Please remember, okay, agentic AI is the next phase of healthcare in AI. And by combining autonomy, reasoning, and learning, it can significantly transform clinical care, medical research, and healthcare management. So, my dear delegates, let me tell you one thing, that as I started, technology is there. Technology has come to the fore. Without technology, without AI, you are going to be obsolete. It is up to you to decide whether you want to use AI, whether you want to adopt AI, and whether you want to have AI systems. Definitely, it is up to you. And if you don't want to do it, you will become obsolete. You will be nowhere. In America also, I've seen that most of the people who are there in data analytics, it is tons and tons of data comes from healthcare. Tons and tons of data, and a lot of healthcare professionals are working on analyzing data using AI tools. So it's up to you to decide, and if you want to remain relevant, you don't want to become obsolete, and it's up to you to take a decision. Definitely AI is there, and AI is going to be there for the next many, many years. IT might be there for some years, but AI is going to continue for many, many years. And in case you want to be relevant, definitely I would say that you need to adopt AI, and you need to be very adaptive also. Thank you all very much.
Thank you, sir, for your inspirational and enlightening session. As we approach the conclusion of the session, it is time to express our heartfelt gratitude. May I invite Ms. Muriel Gomes, Assistant Professor and Coordinator, MIT, to deliver the vote of thanks.
Good afternoon to one and all. It is my great pleasure and honor to propose the vote of thanks for Acharya's first National Conference on Allied and Healthcare Sciences, ACAHS 2026. On behalf of Acharya Institute of Allied Health Sciences, I extend my heartfelt gratitude to our distinguished dignitaries who have graced this occasion with their presence. First and foremost, I sincerely thank our keynote speaker, Professor Vishalakshi Ji, whose remarkable contributions to allied health education and professional development have significantly enriched the field. I also thank Dr. Sarita Kamath for her valuable insights today. I would also like to extend my sincere thanks to Professor Iqbal Ahmed, Director, Collaborations and Growth at Acharya Institutes, Bangalore, for delivering an insightful technical session on AI and healthcare, providing valuable perspectives on the role of emerging technologies in transforming modern healthcare. In absentia, I would like to appreciate our visionary leaders of Acharya Institutes, the Chairman, Premnath Reddy Sir, our Executive Director, Mrs. Shalini Reddy Ma'am, our Managing Director, Krishna Basani Reddy Sir, our Executive Secretary, Mr. CBM Bhushan Sir, for their administrative support and directions to our institutions. My heartfelt appreciation to Dr. Bhagirathi Bai, Director, Academics, for her visionary leadership and encouragement, and Dr. Debashish Pradhan for their constant support. A special gratitude to Dr. Venkatesh Jayadat Sir, our principal, Acharya Institute of Allied Health Sciences, for his unwavering support and leadership in making this conference a grand success. I would like to place on record our sincere appreciation to our dedicated research coordinators of AIAHS, Mrs. Priyanka Patnaik ma'am and Mrs. Neha Martin ma'am, who have planned and worked so hard ensuring the smooth conduct of this conference. Our heartfelt thanks to all the session speakers and faculty members from various institutes for sharing their expertise and enriching this academic platform. I also extend my gratitude to the faculty members, volunteers, and students of AIHS for their active participation and dedication. A special word of thanks to all the delegates who have traveled from different institutions to be a part of this conference today. Your presence adds immense value to this conference. This event would not have been possible without the tireless efforts of our support teams, which is the CPRD team, maintenance, housekeeping, transport, and all the other supporting departments for their coordination throughout the conference. Finally, I thank each and every individual who have contributed directly or indirectly to the success of this conference. Let us continue to work towards strengthening allied healthcare sciences throughout education, research, and collaboration. Thank you all.
Thank you, ma'am, for that gracious expression of appreciation. We now proceed with the felicitation of our esteemed keynote speaker, Professor G. Vishalakshmi, ma'am. As a token of her gratitude and respect, I now invite our respected principal sir to felicitate her.
Sir, Dr. Iqbal sir, I would also ask you to come and join us in felicitating. Ma'am, please come. Please come.
Thank you to our esteemed speakers and dignitaries for gracing this section and enriching the National Conference Alliance 2026 with your presence. I request all the participants to kindly proceed to your respective auditorium for the section. We will return to this venue for the panel discussion in the later half of the day. The tea has been arranged outside. Kindly disperse to your respective departmental venues. ATOT and RCT, kindly stay back after your tea break. RDT to the CSC block. We would also like to felicitate Mr. Iqbal Ahmed sir for his presence and his graceful presence for his inspirational speech. Thank you, sir. So RDT, I think everyone can disperse, all the delegates can disperse to your respective venues. Kindly have the tea. Tea is arranged outside. Okay, volunteers will help you out or guide you to your respective venues. After the tea, RDT and RCT department students can come back to this main auditorium. RDT should go to the CSC block. MIT students to the mechanical hall. MLT students to the MBO auditorium. Volunteers are there to help and guide you to your respective venues.
improved accuracy, reduced human error, where AI makes less mistakes when compared to human. Better clinical decisions. With the help of AI analyzation, we can make better clinical decisions as we make accurate decisions on the treatment. Predictive analytics in healthcare. It is one of the smart healthcare system technology. Predictive analytics uses past and present data of the patient to identify the health risk. How example of predictive analytics, it predicts the risk of sepsis. It predicts the risk of sepsis before the symptoms become severe and helps the doctor to treat early and save lives. Another example is it identifies the patients likely to develop cardiac complications. How it helps us, how predictive analytics is helpful for us. Firstly, it detects early signs of disease, then it predicts possible complication that patient may occur lately, and then it allows the healthcare workers to take preventive actions. Key outcomes for predictive analytics are, the predictive analytics is the best and most crucial smart healthcare technology that I can say you. It goes with the early intervention for better patient outcome. Next is digital twin technology. What is digital twin technology? Digital twin technology is a virtual model of patient created using real medical data of the patient. It helps doctors simulate treatment responses, some of the doctors get confused during the treatment, so it helps us to test different kind of therapies, plan personalized treatments. Advantages of digital twin technologies are, we can use personalized medicines as we got the results, and reduce treatment risks, and planning of the care given by the doctor to the patient will be improved. The best example for digital twin technology I can give you is taking a patient virtual model of heart. Doctors take virtual model of heart of the patient and add all the medical data such as heart scans and other medical data of the patient, and helps doctor puts different kind of treatments and medicines along with their prescription, and then doctors will be helpful in getting all the treatments by the digital twin technology. It will help doctor in safer and faster diagnosis of the patient. This one is real world application of intelligent healthcare. Smart healthcare technologies are already being used in hospitals. Example, AI in radiology. AI assists in radiologist technicians to detect tumors and fractures and abnormalities in medical images. AI in laboratory diagnosis. AI analyzes automatically and interrupts lab results and detects abnormal patterns such as decrease in creatinine level, decrease in cholesterol level, and remote patient monitoring. Variable devices present in the hospital tracks heart rate, glucose level, oxygen saturation, and send alerts to the patient, to the doctor. Clinical decision support. AI tools help doctor to choose the most appropriate treatment and based on the patient's data. Smart healthcare technologies are present. That doesn't mean that there is no need of healthcare professionals in the hospital. They require healthcare professionals, but with the availability of smart healthcare system, it will be easier and faster for them to diagnose the patient. Key benefits are improved speed. Speed of the treatment will be improved, accuracy in the treatment, and efficiency in healthcare delivery. And the places where smart healthcare system is common in countries is US, UK, China, and Singapore, and India. In India, the best states that are Karnataka, Telangana, Maharashtra, and Tamil Nadu. In Karnataka, Bangalore is the most common place where AI, a smart healthcare system, is developed. In Bangalore, there are the institutes such as Apollo Hospital, Manipal Hospital, Narayana Hospital of Cardiac Institute. Challenges and ethical consideration. Apart and despite from the benefit, intelligent healthcare also faces challenges such as data privacy. Medical data must be protected and securely stored by the doctors and dependence on technology. Healthcare workers must be dependent on technology and will be in use of clinical judgment. Cost of implementation. Advanced systems may be expensive for smaller hospitals. Training requirements. Healthcare professionals need training to use new technologies in smart healthcare system. Technology should not support healthcare professionals, but it should replace them. Conclusion. Intelligent healthcare systems are transferring healthcare by focusing on prevention, which is done by AI, early detection, which is done by predictive analytics, and personalized treatment, which is done by digital twin technology. And integration of AI, predictive analytics, and digital twin technology helps allied health professionals deliver more efficient, safer, faster, and patient-centered care. Healthcare is moving from treating illness to predicting and preventing it through the smart healthcare system and technologies developed in our India. This is my reference, and thank you.
Next, I invite R. Sandra.
Good afternoon to everyone present here. Myself, Sandra, from Department of Cardiac Care Technology from Avi University. And today I'll be talking on invisible yet indispensable, perceived undervaluation of allied health professionals. So talking on the background, so on the modern healthcare systems, there is no doctor-centric care only. So we do have in the hospital or the healthcare system, we have primary, secondary and tertiary. But then what is the difference between tertiary and both primary and secondary? The doctors are there present in both primary, secondary and tertiary. But then the distinct feature of the tertiary is that allied health professions and their services. So what all services do we give? So basically we have cardiac care technicians who work in the cath lab, and radiologists who do the imaging, and respiratory technicians who work for the ventilators, and physiotherapists who aid rehabilitation, and laboratory who do the analysis and diagnostic centers. What will happen if there is no presence of AHP in a healthcare setting? If there is no AHPs present in a healthcare setting, there is no ICU efficiency, there is no diagnostics happening, there is no analysis, and there is no rehabilitation after Q. Yet, the organizational and the healthcare hierarchy still focuses and keep the physicians in the top tier. Yes, of course, doctors are the life saviors, but then the distinct feature of the tertiary care, without allied health and professions, it cannot happen. But then we are still not involved into major things. So what is the problem we'll be facing? So the problem statement is not about salary alone. It is about the acknowledgement. So whatever work we do, and we actually have a lot of commitment towards our work. We have overloaded work, but then we don't have recognition. So we are not being acknowledged, and we are not involved in decision-making statements or arguments, and we are also not given a proper career ladder. So if there is, so basically people after allied health and professions, they don't know what next to do. Even if they know what next to do, they are very clear that we are not going to be recognized. So people often quit this course and they go to something else. So what will be the impact on this? Because of these problems, it will have a low job satisfaction, burnout and turnover. This will make the people to quit this allied health professions. And so there is two objectives for today's research what we have done. So it is primary and secondary. In the primary, we'll be seeing about what extent of the healthcare professions are affected by the undervaluation of their job. And in the secondary objective, we'll be seeing about how the proportionality between the higher undervaluation to lower job satisfaction. So the method to do this research is cross-sectional survey. I have taken cross-sectional survey as a suggestion to do this study because it will cover a wider range of people over a short period of time, and this will be conducted in tertiary care hospitals with the participants of licensed allied health professions, and the sample size will be 150 to 200. So what will be the thing happening in the analysis or the cross-sectional study? So we'll basically have a question area domains which will have questions such as professional recognition, role clarity, decision-making involvement, career advancement, and job satisfaction. And this will be analyzed based on descriptive studies, Pearson model, Pearson correlation. So basically, after this studies, this is a futuristic study. But then according to data which has already been recorded, these are the key findings. We have a moderate level of the people who tell that they have perceived undervaluation. They have significantly noticed that they have been undervalued for what job they are doing. And there is the highest dissatisfaction in the decision making and career growth. So people even with expertise for 10 years or 12 years do not have the recognition or acknowledgement being in these professions. And negative correlation with job satisfaction. So talking about the Pearson correlation which I showed in the previous slide, over there is P less than 0.05. So that basically shows the negative correlation about how the higher undervaluation is related with the lower job satisfaction. And there is always an interpretational between the workers, their work, and the organization which is conducting this. So the interpretation is that organizational hierarchy influences recognition, limited governance inclusion affects autonomy, workforce model linked to structural support. So the personnel, like whatever goals they have, that is always aided with the structural support. But then that structural support is not given to us because they do not identify us as a department. And before talking about the limitations, what is the major problem? In the problem statement, when I stated the problems, it is always said as we are a professionals, we are reading allied health professionals and we are getting a degree out of it. But then when we go and work out in a hospital setting, we are always called as a supporting staff and never a professional. So that is something which makes us to get exhausted and gets a burnout. And limitation, since it is a cross-sectional design, we know what is affected, but then we don't know the causes. And since it is a self-reported data, it can be biased according to their benefits and needs. And it is limited only to tertiary sector of hospitals. And conclusion is that undervaluation is measurable organizational issue, and recognition and structural growth pathways are critical. Policy level integration of AHPs is necessary. So basically when we apply for any policy related to our job, there is no policy integration for allied health professions. So if there is a policy which is going to be involved inside this tertiary hospitals, these will be the recommendations: structured career models, leadership inclusion, regulatory strengthening, institutional recognition mechanisms. So before ending the slides, I would like to talk about the controversial topics. Everyone says that AI will replace or take over all the allied health professions' job, or they don't need allied health professions. So I would like to illustrate within our interesting object of everyone, a favorite object of everyone present here, a mobile phone. So there are majority of the adults, many adults above 30 do have an iPhone. They do own an iPhone. But then if 50% of the people know how to use an iPhone, there are other 50% of people who don't know how to operate an iPhone. So if we have to search something search something about the world or know something, people having an iPhone do not go search things in Safari. They instead search for Google inside the Safari. So I like to say that for their understanding, for the basic understanding of the people and the patient, more than talking about the recognized medical professions, they do need a basic Android system, and that is us, medical health professionals, allied health professionals. Thank you. Any questions?
Next, I would like to invite Siddhika Banu.
Good afternoon to one and all present here. I'm J.S. Siddhika Banu, DOT from Diploma in Operation Theatre and Anesthesia Technology from Shamma Institute of Medical Science. So my topic is on robotics in minimal invasive surgery. So introduction. When we think about the robots, we often think about the machine that will work like the humans, but in the reality, robots are doing a task in the operation theaters today. Robotic surgery is basically the use of robotic arms, tools, and the real-time detailed view and the 3D advanced camera in the console during the surgical procedure. So current surgical robots are controlled by the voice, remote, or the joystick controller. So coming on to the history. In the era of 80s, the first surgical robot called Puma 560 was used for the CT-guided brain biopsy procedure on April 1985 by Dr. X Sanwo for the beginning of the surgery. In 1988, the Probot surgical system was introduced by Sir Brian Davis. It is used for the prostate gland surgery. In 1990, the ESOP surgical system was developed by Sir Yulu Wang. It is used by the surgeons where controls the camera during a laparoscopic surgery. In 1992, the Probot Doc surgical system by Dr. Howard Hap Paul and Dr. William Barger. It is used mainly for the orthopedic surgeries, example like hip replacement. In 1993, the Zeus surgical system by Sir Yulu Wang, which improves in doing surgical assistance. There are 3 types of surgical system. First, Da Vinci surgical system, telesurgical system, and 5G remote surgical system. So, the first Da Vinci surgical system has introduced by the Dr. Frederick H. Moll in 1999. So, Da Vinci surgical system is a robotic system which run by a surgeon to perform an operation include a surgeon console, patient cart, vision cart, and the camera monitors and the cautery machines. It is the first FDA approved by the robotic system for the general surgeries. So robotic surgical console is located within the operating area. Why it is kept separate? Because if they require any suture or a medication during a procedure, they can go and bring for the patient need. So that's why the surgeon console is kept separate. So this is the computer surgeon console, that is camera view, which is vision card, and the robotic arms are the patient card. This is the real view of robotic surgery. So coming on to the advantages and disadvantages of Da Vinci surgical system. First advantages are the main advantage is to provide high definition view of surgical area. Second, endovis instruments, robotics can move freely more than the human hands. It can rotate 540 degree from a robotic arms. Over 40 types of instruments we can use. The main disadvantage is high cost, high maintenance charges. Surgeon required very specialized training for the severe conditions like obesity peoples. History, multiple abdominal surgeries performed. Next, benefits, reduces discomfort for the surgeons during wrong procedure. It takes faster recovery time compared to the open and minimally invasive surgery. Minimal incision reduces post-operative pain, lower infection on surgical site, shorter hospital stays, and lower the risk of complications. These are the surgeries are done from robotic system. So, development and future in robotic system. First, enhance surgical capabilities where it improves precision and controls during the operation. Integration of AI, artificial intelligence, integration of artificial intelligence which makes the decisions. In future, we may see more autonomous features such as tissue identification and surgical assistance. Surgical education and skill development, and it is more portable and easier to use. Next conclusion. These all robotic systems are US Food Drug Administration approved, and from early machine to today's advanced robots, it has changed what possible in the surgeries. Doing surgeries from far away could bring experts to people who can't easily get afford to the hospitals. We need to work on making sure this technology could be affordable, and doctors should well train so that the robots can help surgery safer, work better, and be available to more people. Thank you.
Next, I invite Yavar Hassan.
Good afternoon, respected judges and everyone present here. I am Yavar Hassan Chopan from Sri Lakshmi College of Allied Health Science, Bangalore. Today I'll be presenting the topic Artificial Intelligence in Anesthesia, Transforming Perioperative Care. As we know that artificial intelligence is rapidly transforming healthcare in many areas. But in case of anesthesia, it's having the potential to improve the monitoring, helps in decision makings, and improves the patient safety in overall in case of perioperative care. In this presentation, I will briefly discuss how AI is being used in anesthesia and how it can improve the patient care in future. Artificial intelligence is rapidly transforming in many areas of healthcare. It analyzes the larger data and helps the clinicians or the doctors for quick decisions. As we know, in case of anesthesia, it's mandatory to have the continuous monitoring, and quick assessments or quick decisions are required. Why? Because during the surgery, during the procedure, anything can happen. That means any complication can occur. So in order to overcome that complication, in order to reduce that thing, AI helps us in case of predictive analytics and precision-based care. Therefore, in this presentation, I would like to explore the applications, benefits, challenges of artificial intelligence in modern anesthesia practices. For this study, a narrative review of published literatures was done. Certain articles were searched by using PubMed database, which entirely focuses on use of artificial intelligence in perioperative care, especially in case of operation theater and intensive care unit. These studies also include the predictive algorithms and closed loop systems. Closed loop systems is actually an automated system that will help us monitor the parameters of the patient, that will help in case of ventilatory support, and that will help us in case of better control of drug dosage. The result shows that the artificial intelligence plays an important role in case of perioperative environment. It improves the patient safety, as we can say, during surgery or during anesthesia. So it will predict the hypotension early. So we can say during surgery, hypotension can be predicted early and it can be treated as early as possible. So closed loop system, it will improve us or it will help us in case of better control of drug dosage, early warning algorithms, so that will help us in case of detecting the complications like sepsis. And one more thing, AI-based ventilators will help us in case of respiratory support. So in a nutshell, I can say this: artificial intelligence plays a crucial role in case of perioperative, or we can say rapidly transforming in case of perioperative care. So it helps the doctors, it helps the clinicians to make the quick decisions in real time. It moreover improves the patient safety and efficiency. Along with that, it supports the anesthesiologists by providing the data insights. But however, it requires the ethical regulation and clinical validations. So one more thing I want to mention here, that is artificial intelligence is a supportive tool. So it is a supportive tool, so it can't replace the clinicians, it can't replace the anesthesiologists. So, but the thing is, the anesthesiologists or the doctors, those who are using, those who are implementing it properly, they will get the better results than those who are not utilizing it properly. So I would love to express my sincere gratitude to my faculty members and my mentors for continuous support, and I would like to say thank you to the Acharya Institute of Allied Health Sciences, and last but not least, I would like to thank the organizing committee of this conference for conducting such type of conferences, for providing such type of platforms to the students, and for providing me an opportunity to speak in front of you people. So these are certain references, these are certain scientific research what I have used for my presentations. So these are some articles what I have used for my presentation, and these are actually based on the artificial intelligence. Thank you, have a nice day. If anybody is having any question, you can proceed. No questions? Okay, thank you.
I welcome Mrs. Maumida ma'am and Ms. Insha ma'am to do the faculty presentation.
Good afternoon, dear students and my dear colleagues. Today, I and my colleague, Ms. Imsha, are going to present on the efficacy of using various machine learning models for the detection of patient ventilator asynchrony in hypoxemic respiratory failure. Over to you, Ms. Imsha.
Good afternoon all. Patient ventilator asynchrony occurs when there is a mismatch between the natural breathing of the patient and the breaths delivered by the ventilator. It is most commonly observed in the mechanically ventilated patient up to the ranges 10 to 85%, and it increases the work of breathing and can also lead to ventilator-induced lung injury. Patients with acute hypoxemic respiratory failure are vulnerable to the different type of PVAs such as double trigger, reverse trigger, ineffective effort, which may make the ventilator management more challenging. Although manual ventilator waveform analysis is a gold standard technique for the detection of patient ventilator asynchrony, it is a time consuming and completely depend on the clinician's expertise. Although the recent advancement in the artificial intelligence and deep learning models such as CNN and LSTMs have shown promising performance in the detection of ventilator asynchrony, with the studies reporting high F1 scores above 0.9, showing the strong detection accuracy. The rationale of our study is to address the gap between the clinical burden of PVA and limitations of the manual method by systematically evaluating machine learning algorithms used for detection of PVA. Over to you, ma'am.
Moving on to the methodology of this study. So we have done a systemic review based on PRISMA 2020 guidelines. For collection of data and articles, we have used 3 major databases, PubMed, Embase, and Cochrane. We have also searched systematically using the snowball technique in Google Scholar, and also citation searching was done. So a total of 10 articles is what we have got for this particular systemic review. This systemic review has also been registered in the Prospero trial. So coming to the inclusion criteria, we have included only original studies where machine learning tools were used to detect patient ventilator asynchrony in hypoxemic respiratory failure patients, and where the performance metrics of such tools were reported using accuracy, sensitivity, specificity, or F1 scores. However, any studies which have involved pediatric patients or were not original articles, were just abstracts or letter or editorials, were not included in this study. So this is the PubMed statement, and this is how we have funneled down the studies. A total of 29 studies were involved at first, and after funneling down, we had 10 studies. These 10 studies were obtained, and they were high quality, had all the inclusion criteria. As per the inclusion criteria, all the criteria were met. And so in order to judge the risk of assessment for those 10 studies, we have used the Robbins 1 tool. So this particular tool is used for finding out if there is any risk of bias in non-interventional studies. So you can see the heat map here, where it shows that all our studies have low risk of bias. However, some of the studies you can see that has D6 and D7. That means the outcomes and the report of the results were having some moderate bias, and that is basically due to inter-observer reliability. So every paper was systematically and individually analyzed in all the major domains of confounding, of selection of participants, and how the outcomes were measured. So this is the table of the various studies that we have included. So just to summarize the result, we have total of 10 studies where 7 were prospective and 3 were retrospective. A total of 715 patients were included in the study. 40.8 million breaths were analyzed. Among all the breaths which has been analyzed, the most common type of patient ventilator asynchrony were reverse triggering, double triggering, and ineffective efforts, which we have seen in hypoxemic respiratory failure patients, especially ARDS. So the best machine learning models which has achieved the best accuracy, which is greater than 90%, were CNN, that is convoluted neural networks and logistic regression, with F1 score of 99.90%, PPV of 97.6%. So coming to the discussion and the interpretation of the results, the analysis of 40 million breaths over these 10 studies shows that multiple machine learning algorithms have the capability of finding out patient ventilator asynchrony with maximum accuracy. So with this, we can actually reduce the burden upon the clinicians, respiratory therapists, and other ICU workers who are there managing the patients. Hence, this particular systemic review is designed so that it gives you an evidence to build future models for the betterment of PVA, especially in patients who are very much at a high risk of villi. However, this study had multiple limitations. Firstly, the results and the study type or study design were very heterogeneous in nature, and the sample size were very less because we could get only around 715 patients who were on hypoxemic respiratory failure. And however, the accuracy or the performance metrics were very much different or divergent in multiple studies. So these are the limitations which I can quote. And next, this also provides a recommendation for the future studies to avoid these limitations and come up with real-time models that will help in ICU and also in multiple other departments. So moving on to the conclusion. So I request Imsha ma'am to conclude the following topic.
In conclusion, our systemic review demonstrates that the machine learning algorithms such as the neural networks helps to show the highest accuracy in the detection of PVA in hypoxemic respiratory failure patients. Neural network driven detection systems shows a strong potential for accurate real-time identification of PVA, and it also helps to enhance the ventilator management in the patients. Although these results are promising, but here, the further large-scale validation and standardized implementation are required before routine bedside integration. Now, at the end, we would like to express our sincere gratitude to Ms. Ameya Shetty, Manager Business Operation, and the Department of Respiratory Therapy Technology and the Department of ATOT Technology, Narayana College of Health Sciences, Bengaluru, for their academic guidance and constant support throughout this preparation of the systemic review. These are the references we have used for our study. Thank you. Any questions?
Thanks for eye-opening sessions of young generation, ma'am. We are truly inspired. Thanks. I welcome Mrs. Maria Shaji, ma'am, PhD scholar from RV University in the Department of ATOT for oral presentation.
Good afternoon. I am Maria Shaji, Assistant Professor, School of Allied and Healthcare Professions, RV University. So my topic is a systematic review titled, Does Prediction Translate to Prevention? It is an AI-based hypotension monitoring in the operating theater. So there was one student who actually told about AI in predictive monitoring. So one of that was hypertension. So my systematic review as well follows the same. So this review examines how predictive monitoring, or if predictive monitoring can actually help in physiological or clinical outcomes. So we have patient-centered outcomes in picture. To begin with, intraoperative hypotension is something which is very common during major surgeries. That is, it is a common complication during non-cardiac surgery. So I have taken only non-cardiac surgery, and it is the most common complication. So here what happens is, most of the studies suggest that even short periods of drop, so there is this graph where there is mean arterial pressure, which is labeled as 65 millimeter mercury. So if at all you have shorter periods of drop from this pressure, we do have diseases associated or complication associated with acute kidney injury, myocardial injury, and post-operative mortality. So what we do right now is a traditional monitoring. That is reactive. So whenever there is hypotension fall, or like the blood pressure fall, that is when you give fluids or vasopressors. You do the intervention based on the detection or when things happen. Here recently, we are all talking about AI, predictive monitoring, and machine learning. So in this era where machine learning and AI and all is there, we have this concept of predictive monitoring. So what happens is most of the studies have shown that using AI, and here as I've taken hypotension, so where there is machine learning which is used to detect mean arterial pressure waveforms. So you have these graphs going up and down like ECG graphs. So when you see those, you can actually detect, or like the AI can predict it before 5 to 15 minutes before the onset. So that is one advantage. And then this will also give the clinicians to respond according to the alert. So if it is happening 5 to 10 minutes before the onset and then there is an alarm going, you can actually intervene it even before the onset happens. The methodology I have used is a systematic review. So this will just be a Prisma flow. I have looked into PubMed and Cochrane Central. So these were the databases searched. I have done only inclusions where we have adult patients, non-cardiac surgery, and then it is compared with HPI monitoring. That is the hypotension prediction index, where the analysis will happen along with the traditional care. Now this one, after the screening of the literature, that is after the first 4 boxes, you have the 5th box. So what happens here is you get only 7 literature, which kind of says that, yeah, you can have all of these inclusion criteria, and I have got about a sample size of 1,497 patients. Now, because of the results being heterogeneous, that is, difference in results were there across the studies, hence I have done a qualitative synthesis. The key findings, the first key finding itself is related on intraoperative hypotension. That is 7 out of the 5. So 5 studies out of the 7 studies that I have finalized showed that there was significant reduction in hypotension in the perioperative care. So what happens here is we do have reduced time-weighted MAP, that is mean arterial pressure, which is below 65 mmHg. Another thing was, even if there were hypotensive events, they were of shorter duration and fewer episodes. The clinical outcomes, that is, there were 2 things to my problem statement. If the AI predicts monitoring, is it physiological alone or is it patient-centered? So clinical outcomes are basically for my organ injuries. Now, most of my studies, that is, out of the 5, 2, most of my studies did not show any consistent reduction in acute injury, acute kidney injury, myocardial injury, the reduction of the hospital stay, or even the mortality part. So here we can actually say that, yeah, AI predictive is helpful in the physiological outcome, that is, the BP control was happening, but then we do not have clinical outcomes as such. Why this happened, or like what were the causes for the results to be that way is probably because my studies were single-centered. That is, a single unit were used with the smallest sample size. Another thing was AI is a proprietary technology where industries will come into picture. So clinical outcomes are not studies as such. So we have methodological gap and the human factor. My study has limitations as well. So I searched only within PubMed and Central. That is a Cochrane Central. Embase I did not have access to. And out of the 9, so there were totally 9 texts which was actually proved. And out of that, only 7 came up because 2 texts were unavailable. Then most of my study designs were single-centered with lesser sample size. The metric variance, that is the heterogeneity, the difference in the results were varied across the studies. And then the industry influence. As I said, AI is a proprietary technology. In summary, as of what the study says, AI predictive monitoring is helpful in reducing intraoperative hypotension, but we do not have consistent improvement in your clinical outcomes or patient-centered outcomes. Therefore, the future scope of the study is whenever if there are people or if there are researchers looking into multi-center or larger sample size, then probably where they are focusing on clinical outcomes, then probably we can come to a positive conclusion. That is it for my studies. So these are my references. This will be my shorter version of the Prisma flow study, where those were the studies which were taken off, and then we had the screening. the eligibility, so that is what the 5+2. So you have the 2 texts which were not available. And then the RCTs, that is the randomized controlled trials, were of 7, where 1,497 patients were included in the study. Thank you so much. Do you have any questions? Thank you.
Happy congratulations for all winners. Stay motivated. Hope you gain some knowledge from the day. Thanks for joining.
As the last session of the conference, we have panel discussion. Please stay back. Don't forget to collect your certificates. Happy learning.
Hello all. The peoples from RV University and Kaushi College, please from the Department of RCT, if you want to get certificates, please come to the corridor. How many of you there from Kaushi College?
ATOD students from MVM college, come and collect the certificates. Okay. ATOD students from MVM.
Ma'am, I'll just ask one last time because I have certificates. Problem, but I'll tell you one thing, certificates are limited, they are printed. So that's why I have the problem. You can do one thing.
ATOD.
Either I can do this or that. I can't do both. That is the problem. And one more thing, this is not it.
That is what's your destination?
This is oral presentation. You have sent it?
It's there in group actually. It's not working.
Sorry, it's okay. The RCT students from RV universities are there? Who are registered for cardiac care technologists, right? Yeah.
Anyone from Shama College? Shama?
Yeah, only two.
And one faculty also.
Yeah, one faculty, that's all.
Shama College. So this is need to be given, no? Narayana, somebody come and collect the certificates. Okay. RV. Don't mix, okay. Check the numbers, okay. Any RV will give. RV. Total how many are there? Just check, okay. Check the numbers, okay. You have to like distribute now itself, not after reaching the college. Okay, give the everywhere.
Participation certificate, this is, right?
Rajarajeshwari College. Rajarajeshwari. How many are there?
Sir, 80 OT we have 5
members.
80 OT, only 80 OT, sir. Other
Okay,
department.
only 80 orders. Okay, you distribute now itself. Okay, the name is not mentioned. You can write yourself. Okay. Acharya.
Sir, if you are giving certificates to the colleges, tell me, sir, how much you are giving? Please, I have a count. Given for how many colleges from ATOT?
All the colleges are being given only. Our college is.
So, may I know how much you have given?
The numbers
From
are
each
there in the
college.
list. Accordingly, you give the number. No. The registration. How much is there?
Because, from RV you have given.
RV given.
30 was there, 30%.
30. What can I do?
Shama Institute. Shama Institute.
RCT students from ACAHS. From ACAHS institution, RCT students are there?
Check.
बैटरी हाँ उसमें नहीं था रिप्लेस करने के लिए ओके डन सर
Good afternoon to one and all. Healthcare innovation today is not driven by individuals alone, but through collaboration between clinicians, researchers, technologists, and industry leaders. This section will explore how powerful ideas evolve into real-world impact through meaningful partnership. We now move into an existing and thought-provoking section of the today's program, our panel discussion titled From Idea to Impact, Collaborative Innovation in Healthcare. To introduce the panelists, I would like to call the moderator, Mr. Charlie Daniel, Assistant Professor, Department of Medical Imaging Technology, onto the stage.
Good afternoon, one and all. I would like to invite the panelists onto the dais. Dr. Sarita Kamath, Mr. Rishabh Majumdar, and Mr. Punit Kumar. Good afternoon. May we maintain silence so that we can get on with the panel discussion? Welcome to our panel discussion, From Idea to Impact, Collaborative Innovations in Healthcare. Healthcare innovation today no longer happens in isolation. It requires collaboration between clinicians, researchers, engineers, industry experts, and allied health professions. Today, we are fortunate to have an exceptional panel of experts representing diverse domains of healthcare who will share their insights on how to evolve into impactful solutions that improve patient care. Let us begin the discussion. I would like to direct my first question to Dr. Sarita Kamath. Ma'am, diagnostics play a crucial role in modern healthcare. How can innovations in laboratory technologies and biosensors help move healthcare from reactive treatment to proactive disease management?
Thank you for inviting me here. So actually biosensors nowadays having very good role, and we have to first we have to find out the challenges whatever we are facing in our area. So by using that one we can't give the solution our own. So we require other departments also, along with that industry has to collaborate. So we can go through the articles and we can find out the research gap, and we can take your help so that we can give our ideas and we can come to the conclusion and we can go for further research in that area. So this is what I'm feeling.
Thank you, ma'am. I would like to add a follow-up question. As someone deeply involved in research and academic leadership, what strategies can the university adopt to foster collaboration between researchers, clinicians, and industries?
Actually, our university last year we have celebrated as industry academia collaboration. So during that time, so we got many tasks. So many times we called industry people for conduct that workshop so that our students will get that more means expertization in that area. Also we called industry people, those who are having more knowledge, to give some talks regarding that developing area for our students. And sometimes the innovative modern equipments they brought and they gave that workshop also. So along with that, clinicians also can tell what they want and we can give our expertise in that one. So with everyone's idea together, we can collaborate with the industry. So that's what, so even during when we conduct any conference, we can give 1 or 2 sessions for them so that they will give that whatever updation in industry. So industry in quality and all, we require your help also. Whatever we teach them in the academics, the theory, practical, whatever we know. But what exactly happening in the industry, we may not be knowing. So those expertise we require from their side. Thank you.
And I guess conferences like this helps us collaborate.
So really, means we meet many people, so with many background. So even here also, each department, one person can come together and you can prepare one small research group. So by including industry people and clinician, so that we can go for more innovations.
Thank you, ma'am. I would like to direct my next question to Mr. Rishabh. Medical imaging has evolved rapidly. From your experiences in MRI product development, how important is clinician feedback in shaping the next generation of imaging technologies?
Yeah, hello. Thank you for the question. So I would like to start by saying the clinicians, they definitely play a pivot role in this, and we can never exclude them. So that will be very different. So we will be making something and they will be expecting something else. So we cannot just develop on our own anything. So each and every step of this iterative product development, we include the clinicians. We keep getting their feedbacks. And based on that, we keep adapting the need. We keep on adapting the outcomes. So this also helps us in knowing the different, so let's say I have some requirement from them, and when I've started developing something and the requirement changes, so now they want something else. So if I had made something already and published, that wouldn't have made sense. So definitely the clinicians are really North Star in case of getting feedback when we are developing. This also helped us develop our this whiteboard. So we keep getting problems from this, the technicians, the doctors, they keep saying the patients, we have to abort the scan, the patients are going back. So that is how this new invention came, that is how we increased our board size. So even each and every feedback matters during our development.
So is innovation because of the need of the heart, or it's because of the clinician's comfort?
So this is a very good question, why I would say. We will have all the listed out requirements, both from clinicians, something the clinician wants, and then there is something what the market is asking for. So I would say definitely most of the time, we try to make a balance between it, and we can see if the clinician agrees that he can wait for some more time. So we push for something which is the market really needed.